comment is to try and tie this discussion back to where we started this morning, which was the results of the patterns of care study. And that is one of the most striking results that Diane presented to us was the large group of patients with stage 1 or stage 2 disease that appear not to make it to treatment with curative intent. And as an active, I mean, we could debate this issue almost ad nauseum about in all sorts of ways. But I'd like to ask the panel perhaps to comment on, at this point, in relation to Kathy, what we could do as a group to perhaps close the gap on that, you know, more than 20% of patients with potentially curable lung cancer, to get them to a point where they're actually having some treatment with curative intent. Because I think that's perhaps the gap that we, as clinicians, all of us, multidisciplinary, could perhaps affect the greatest change. Let's assume that it's PET negative other than that isolated 2.5 centimetre lesion, and the CTs must have, you know, maybe 2 centimetre nodes that don't light up on PET.
Okay.
So we'll stage her as a 1A. So she's the sort of patient that that should be treated with curative intent. But Diane's, the pattern of care study showed us this huge, surprising, devastating really, large group of patients who, for some reason, and it may be patient-related issues, it may be clinician-related issues, it may be access-related issues, but it's certainly a systems issue. There's some reason that a huge proportion of those patients are not getting access to or getting to treatment of curative intent.
Okay.
And if this day really is supposed to be about planning for that, and then I think we should start.
That's a brilliant question.
It's actually worse than what Lucy just said. I mean, it just doesn't make sense, because in fact, to know that you've got stage 1 or 2 disease, you've got to have actually gone quite a long way down the path to figure that out. So it makes no sense to me that anybody would bother to figure out if a patient has stage 1 or 2 disease and then do nothing about it. So it really, to me, I still have some problem interpreting that. Let's just accept there is a proportion of patients, whether it's 20% or 10% or 5%, the fact is if you want to improve outcomes from lung cancer, you are unlikely to do it at this stage by treating more stage 4 disease. You will improve outcomes by making sure that every patient who has potentially curable disease gets the best treatment. In most cases that will be an operation. In some cases it will be radiotherapy when for whatever reason they're not fit for an operation. And I think that the only way you can improve on that is to clearly identify where the roadblock is. Is it at the level of the patient, first of all? Is it at the level of the GP? Is it at the level of the physician that they subsequently see, which may be a respiratory physician in the city, but in many rural areas it'll probably be a general physician. And I don't think we yet have a clear enough understanding of where you need to attack it and what that, and I wouldn't waste actually 2 years trying to get that understanding. I'd probably try and approach all of those. I think patients need to understand and take ownership of the problem, so they need to demand, if you like, some action till it's clear that they don't need something done. We need to ensure that GPs are educated, and I know that this is being filmed and sent to GPs, and it's not disrespect to GPs, it is hard, as we've heard. Respiratory physicians, I think, truthfully, in at least large metropolitan centres, I don't believe are, by and large, putting roadblocks in the way, but for the best of reasons, both busyness and lack of knowledge, once you get outside of the larger centres, that might be a problem as well. And finally, when you get to the people who actually deliver the treatment, again, for better or worse, some of them don't make the right decisions.
I've actually looked at the 593 patients who weren't treated, and in a significant proportion, now I'm not exactly sure, but I think 24% weren't referred on, but another 24% were referred but didn't attend the specialist. So it's probably a mixture of patient and clinician factors that are leading to this lower utilization rate of treatment. And I would make the point, it's not only surgery. there's a lower utilization rate of chemoradiotherapy, which have a significant impact on quality of life, if not survival. So I think that we need to educate both the patients and have lots of information out there for them, as well as the people who are referring, the GPs. And I think the MDTs should take a proactive stance. Where I work, we regularly run education sessions for the GPs in our area, and there's 5 different divisions. We provide contact points with our cancer care coordinator, and as a result, I have had phone calls directly to me and referrals directly to me without a diagnosis. And yes, sometimes they do turn out to be benign, but they are discussed and their radiology reviewed at our lung MDT. And I guess I would disagree with Brian in that I think we should present all our patients at that MDT to ensure that we are getting the correct treatment to try, because often, you know, someone might see, perhaps it's more the locally advanced spectrum, they might see someone, oh, they're not well enough, they're too old to have radiotherapy, chemotherapy, too many side effects. But until you start documenting the decisions and trying to follow the reasons why we might have recommended no treatment, can you perhaps explain the shortfall? And so we encourage documentation. We try to get follow-up to see whether the treatment recommendations were or were not followed. We've done an audit of our MDT for the last year, and in about 10% of cases, we recommended no active treatment. But interestingly, double that number, 20% didn't receive any treatment. And so we're trying to explore, well, what changes? Is it when the patient is faced with the oncologist, you know, outlining the side effects? Are they turned off at that point? Does their performance status decrease? Does their tumor increase? So we're trying to explore some of that. So I think having some data collection and audit is vital to that, as well as education both the patients and the GPs.
No matter what we do, it's actually incredibly hard to present risk-benefit ratios to patients, particularly when they're in this space where they've received a diagnosis and they're not thinking clearly. Often that one consultation, you can win or lose the game in some way, and that's an incredibly difficult thing. And when you throw in stuff where people have certain reactions for all sorts of reasons to tertiary care, you've got a problem. And I will say that I've had some enormously, intensely heart-wrenching consultations where, you know, I've watched patients drift from stage 1 to stage 2 to stage 3 to stage 4 on various forms of alternative therapy, because what's really going on for them is they feel like they'll lose their autonomy. They feel that once they get into the tertiary thing, that's it. They've lost it, and it's not true, and it's perceptual and all those sort of things, but hey, we're not rational human beings. So I'd say that. The second thing I would say is the point of entry is not always clear to us, and there are multiply different points of entry for all the diseases to which we refer. So a patient with a serious neurosurgical problem, for instance, will have a different style of point of entry to the patient with lung cancer, who'll have a different sort of point of entry to the patient with breast cancer. And I do think because of that inherent complexity of the system, it can be quite difficult. And I think that there is a point there where some of our patients fall through the net. I'd love to say they come back to me saying, oh, I spoke to that person and they weren't, I didn't get further than point A, what do I do now? But sometimes they don't come back to me and we've lost them. And I'm very concerned about that break, and I'm not quite sure what the answer is to that. But for me, that's a really frustrating moment.
I think we also have to recognise there's a group of patients out there who actually are well informed and make a very informed decision not to pursue cancer treatment. And they're the hardest group and the most heart-rending group for me to work with, because these aren't people who are frightened or exploring alternative therapies. They're often people who have a wonderful sense of self-identity, who make a very positive decision, and age is not particularly a predictor of that. And it's, you know, one of the wonderful and hard things about general practice is actually helping those people too, and making sure that on the one hand you're not being complicit, you know, in telling them that's the right thing to do. I don't think I do that. But on the other hand, respecting that. And, you know, it's certainly a percentage of your patients with any cancer. The question I think that Lucy raised that's really important: every patient with stage 1 to 2 disease should get adequate treatment. And from a general practice perspective, we'd be saying, well, we thought we did. We thought once we fed them into the system, they're getting state-of-the-art treatment. So from a GP perspective, I think we have a lot of faith in the system. My question, though, as a GP is how can I effectively pick up stage 1 to 2 disease, and I haven't heard sort of solutions for that.
I'm a professor of medical psychology. I see cancer patients. I have done for a lot of years, but most of the patients I see are breast cancer. And I think Brian alluded to, and it's been picked up by other people, there's been a massive change, absolutely unbelievable change in the way breast cancer is managed. And quite clearly we need to have the same kind of debates and the same kind of political push and the same kind of imperative coming from us and from patients to actually produce the same sort of changes. I have never forgotten the first lung cancer patient I met when I knew nothing about lung cancer. He was a president of the Australian Society of Anaesthetists, and anaesthetists, believe me, find breathing very, very important. And it was a huge learning curve for me to work with that man, and incredibly humbling to learn about why lung cancer is just so radically different from all the other cancers that I'd seen. So there's a huge challenge for all of us. We've had a robust debate. We've seen new definitions of affability. But and people are passionate about this, and I think that's a wonderful thing. The really important things that needs to happen for the Cathys of the world is that we have to talk about these issues and maintain our passion and make sure we maintain the dialogue. And I particularly thought what Shalini said in summing up, if we had a lung cancer consensus that took us to a pattern of care that addressed the issues Di raised right at the beginning, wouldn't that be a wonderful place to be? And we're all here trying to make that happen. So would you join me in thanking the panel?